Thank you for joining us today. We will be covering a very important topic: how to address the rising risk population, those patients and members that may not appear on your team's first lists, but very soon they may present with a complex set of care needs. We will cover the strategies and tactics to properly identify and serve such patients in a population health framework. I have the honor today of presenting with Dr. Paul Taylor, co-founder of Philips Wellcentive, and Cindy Gaines, President of Administration at Ascension Medical Group, West Michigan Market. By way of background, my name is Dan D'Orazio, CEO of Sage Growth Partners, a healthcare research, strategy, and marketing practice. Dr. Paul Taylor has spent nearly 20 years as a practicing internist. His experience includes building and implementing clinical quality improvement systems at the physician practice, physician organization, and regional levels. Currently, he is the chair of the Clinical Integration and Oversight Committee for the Lakeshore Health Network Physician Organization, which is a leader in Michigan for clinical quality improvement programs, consistently ranked in the state's top 3 physician organizations. He has served on the Executive Committee and Finance and Operations Committee for Primary Care Network for Trinity Health, Mercy Health Partners, as well as Quality Improvement Work Group for a regional Robert Wood Johnson Foundation-funded Health Information Exchange project. Dr. Taylor graduated from the University of Michigan Medical School and completed his residency training at the University of Michigan Hospitals. He is board certified in internal medicine. Cindy Gaines is the President of Administration at Ascension Medical Group, a growing employed contracted network of 200 physicians and 100 mid-level providers. Ms. Gaines has 28 years of healthcare experience, splitting this time between quality and operations across the continuum. And since the practice joined Borgess Health in 2009, she has led the integration of patient care and integrated program requirements of third-party payers, including pay for performance, to maximize clinical, operational, and financial initiatives, along with aligning physicians, and has attained PCMH designation for primary care sites. So today, as we engage in population health, the notion of risk stratification is top of mind. Often we think about what we call the 5 and the 50, or the 5% of patients that are driving an overwhelming share of costs. In fact, 50% of total healthcare is attributable to these 5% cohorts. It's clear to all of us involved in population health and moving along the continuum to value-based care that the payment, the administration, and the delivery of care is why we need to focus on this small but very sick cohort. And this group can be very consuming. But as we look broader at the arc of population health, there's another segment we call the rising risk. Our patients that yet may not have crossed the chasm into the superutilizer category. However, many patients or members in this panel nonetheless have underlying sets of clinical factors, often on the edge of this high utilization and the declining health status. And left unmanaged and unsupported, their health status is rising to a higher degree of risk. And while these high-risk patients, that 5 and 50, is often a good place to start in the PHM journey because their needs are so evident, a singular focus on this cohort may not sustain an organization from a clinical and business perspective as we try to engage the broader population. And as we'll hear today, the patients who we call the rising risk, they don't develop their clinical complexity overnight. So paying attention in the right way and intervening accordingly can pay dividends for patients, providers, and payers. So as we look at the next slide, we see a big number, $16 billion. It's a lot of money. This is what CMS is willing to pay for just the CCM program, the chronic care management program alone. And as the organization with the largest stake in keeping people healthy, CMS realizes the power of intervening early, catching those clinical conditions that are on the rise well before it's too late to intervene both clinically and financially. And this is just one of the many federal offerings aimed at intervening sooner, in addition to commercial programs across the country who are rolling out their own versions of similar programs. So the $16 billion tells us that while that's a lot of money, quite honestly, it's a drop in the bucket compared to what happens when these people get much sicker and they reach that 5 and that 50 category we talked about earlier. So to put this further in context, half of the US adult population has a chronic condition, and a full quarter of Americans have 2 or more chronic conditions. Chronic conditions account for 84% of all the spending in our US healthcare system. So remember, while we may singularly focus on that 5% that drives 50% of the cost, there's yet another 34% of that 84 that falls outside of that 5% cohort window that's continuing to drive spending, and many of whom we can categorize as the rising risk. And these, when you step away from the numbers and we stop talking about just money, these are, patients, family members, neighbors whose health is deteriorating and they need our help earlier. And we have disparities across our population. The bottom left part of the screen shows that racial and ethnic minorities are faring worse on care and quality metrics, up to 40% worse. So knowing your specific population is also very critical as we try to intervene sooner in the quality and delivery and financing of care. And finally, before I turn it over to Dr. Taylor, visualizing this may also help paint even a better picture. So as you look at this slide, what you'll see in the middle is the largest bubble, and that's diabetes, the diabetic patients. And conservative estimates show that once a person is diabetic, they are $10,000 per member per year more expensive to care for than a healthy patient. But it's very likely that we saw these warning signs. And these warning signs include conditions such as prediabetes and obesity. And you'll see that 30% of diabetics are obese, more evidence that these conditions cannot be treated in isolation, nor do they spontaneously combust and become high-risk patients. On the other side of the spectrum with diabetes, you'll see folks who have cardiovascular disease, hypertension, high cholesterol. So we can often see these signs and these problems building. And experience has shown us that even if we focus on the 5 and 50, each year as we're trying to get better in this value-based care journey, a new wave of patients is going to present, and their complex needs will sort of wash ashore. And it may feel like we're treading water unless we intervene earlier downstream. So what can we do about this? This is certainly not an easy issue. It's complicated. And to help us answer that question, I open the floor to Dr. Paul Taylor and Cindy Gaines, who will walk us through their experience.
Great, thanks very much, Dan. So in my portion of the webinar, I'm going to expand a little bit on what Dan's talked about, primarily from the provider and the provider organization perspectives, and cover a bit about what can practically be done about these rising risk patients so that hopefully as a few of them as possible become high risk patients. So I'm going to go over at a high level a framework, a care delivery framework that can be used for these rising risk patients. It's worked well in my own internal medicine office, at my network, has worked well for our customer partners as well over the years. And then I've got a really good example, a real world example of this framework in action that I'll cover as well. So I think when most organizations start working on population health management and value-based care, they very appropriately first focus on those highest risk, highest utilizer patients. That makes sense, but I think over time, as they have the people in place, the processes in place, they've had success with those patients, that they're going to want to pivot and start to also tackle the needs of their rising risk patients in order to keep as few of them as possible as becoming higher risk. And so on the next slide, we see some of the support, I guess, for that statement. Dan covered a little bit of this, but just a couple numbers. So for those patients who are at risk of developing chronic conditions, about 20% of them each year will go into a higher risk category. And from a pre-diabetic standpoint, for those pre-diabetics who don't have that condition tended to by themselves or their providers or both, 5 to 10% of those each year become diabetic. And we know that the chronically ill cost more. In fact, they cost more than twice per year that those folks who do not have chronic conditions cost. And so as an organization, if you're only focusing on your highest risk patients and not also focusing on your rising risk patients, that could cause financial problems for you over the near term. And so what I wanted to do next is present a care delivery framework that you can use for your rising risk patients. And really, this is a framework that works for pretty much any population health management or value-based care program. But I've put a rising risk spin on it for the presentation today. And so we call this the understand, navigate, and activate approach. And so understand who your rising risk patients are, what their needs are, what interventions that you can apply to them to help hopefully keep them from becoming higher risk. Navigate these patients to appropriate testing, medications, providers, care management programs, and so on. Activate providers and care teams, and of course patients, to get them the care that they need, the interventions that will hopefully make a difference for them. So understand, navigate, activate. And at a high level, I'm going to walk through each one of these. So first one, understand who your rising risk patients are and what they need. So how do you identify your rising risk patients? And I think there are different ways. I've chosen 3 to discuss briefly here in increasing order of complexity. And so first, I think everyone on this call here today knows which chronic conditions put patients at risk of becoming high risk. Things like hypertension, diabetes, chronic kidney disease, behavioral health issues, and there's others, of course. I think it's relatively easy to identify who those patients are. Next would be using commonly available risk models like the Johns Hopkins ACG system, HCC scores. There are others as well. And then even more sophisticated, and probably for those organizations that have been doing this for a while, machine learning techniques, using the right technology to help refine how you're understanding who your rising risk patients are and how you're understanding which of them may benefit from which interventions. And so once you understand who your rising risk patients are, then how do you determine what interventions and needs you should target for them? And so just a few things that we found that work well. So first is to align your efforts with the reimbursement models in play with your patients and in your community. This type of work obviously has a cost to it. There's a technology cost, there's a cost for people, there's a cost for people to work, and so on. And so it's fiscally responsible, I think, to make sure that you're paying close attention to what reimbursement models affect your work, where increased reimbursement can come from, where cost savings can be obtained through these efforts. And then I think it's important also to make sure you're designing your approach based on the resources available to you. And I think one big decision point, one significant factor is whether or not your organization has care managers and care teams. If they do, I think that really opens up some opportunities to extend care to more patients in a higher touch way. But even if you don't have care managers at this point, if you think creatively about the people you do have, you may find that you're able to do things that you didn't realize you could do. For example, if you have providers who spend an hour or 2 each day rounding in the hospital, or maybe they have some administrative time or a half day off a week or something like that, maybe the medical assistants and other staff who work with those providers can use that little bit of time to make a big difference for these rising risk patients. And then finally, I think it's important to make sure that you're tackling meaningful and measurable outcomes. So you don't want to just obviously take your rising risk patients and hand them off to your care team and say, go fix this. You want to have interventions that you've identified that have a reasonable chance of making an impact in these measurable outcomes that you've chosen. And the measurability of those outcomes is important so that you can get feedback on how you're doing. And if things aren't improving the way you like, you can make changes, and then also see the results. So understand. So the next step, navigate patients to the appropriate testing, medications, providers, and so on. I think preventive care plays a role here, and closing preventive care gaps is a good way to keep healthy people healthy, but also those patients that are rising risk from developing preventable conditions. And from a navigate standpoint, you can navigate these patients to your office or to a pharmacy for flu shots. You can navigate them to your health system for their mammogram. You can navigate them to a gastroenterology office for their colonoscopy and really make an impact proactively on preventive care, which is important. You can also navigate the appropriate patients to focused care management programs. So if your organization has a care management program that's tailored to uncontrolled diabetics or uncontrolled hypertensive patients, you can navigate those patients, understanding who they are. You can navigate them to those care management programs to take some action. You can navigate patients to the right medications. That may seem a little strange at first, but medication treatment is part of medical care, and navigating them to that appropriate care is important. That'll feature in the more specific example I'm going to give shortly. But are these patients receiving medicines they should receive? Are they receiving enough of the medications that they need to control their rising risk conditions? And then finally, it's probably a little less important for the rising risk population, but navigating patients to specialists who've shown that they do a good job for the reason for referral, I think is important, whether that's length of stay, infection rate, cost of care, so on. I know that information is a little hard to come by these days, but that's changing, and I think that's part of the navigate portion here. So we have understand, navigate, and then activate. And activate, I think provider organizations can play a role here in activating their providers and their care teams, especially with helping them with the first step, understand. So organizations can help provide technology, can help provide insight, can help provide intervention suggestions. Maybe medical management committees can rally the providers around specific rising risk conditions and interventions, say the first half of this year. And then by activating the providers, then the providers can in turn activate the patients. I think provider organizations like payers have a hard time activating patients, but providers leverage the relationship they have with their patients and can activate them. Care teams as well provide education, these various interventions, follow-up, making sure that patients remain compliant, making sure that the outcomes that you're trying to drive are in fact improving. So understand, navigate, activate, real high level so far, but let's look at a more specific example of this framework in action. And I want to tell you a little bit about the MAP program, which was designed to help improve blood pressure control for hypertensive patients. And so MAP stands for measuring, acting, and partnering. And this program was a collaborative program between the American Medical Association and the Care Coordination Institute in Greenville, South Carolina. And they had 3 steps to their program. And the first was measuring blood pressure accurately for their hypertensive patients, acting rapidly to manage uncontrolled blood pressure, and partnering with patients to promote blood pressure self-management. And so those 3 steps line up, I think, pretty well with the understand, navigate, and activate framework. Different words, but I think same intent. And so let's take a look at this program. So this program included a little more than 21,000 patients at 16 primary care offices over a 6-month time frame. And they navigated them toward a standardized intervention of first-line treatment with ARBs or angiotensin receptor blockers or calcium channel blockers, depending on ethnicity and age, followed by second-line treatment with diuretics if needed, and then if needed onto another diuretic, spironolactone. Now this was for patients with uncontrolled hypertension and controlled hypertension, both. And they favored generic medications for cost reasons, and they favored single pill combos for cost and compliance reasons, like lisinopril hydrochlorothiazide. They worked with local pharmacies to coordinate fill dates so that these patients could pick up not only their blood pressure meds, but their other meds that they were almost always likely taking on the same day each month or each quarter to help with compliance. And they promoted the DASH diet and followed up remotely or in person every 2 weeks or every 4 weeks, depending on the stage of hypertension for these patients. And they had some nice results. So over just a 6-month period, 12 of these 16 practices had a significant improvement in their blood pressure control. For those patients who had uncontrolled hypertension at their baseline, their mean blood pressure went from 149/85 down to 139/80, and 10 points systolic and 5 points diastolic may not at first sound like a lot, but especially over 6 months, I think it's significant. And independent of the time frame, it is enough over time to make a difference in end organ complications of hypertension. And even their controlled hypertension patients at baseline saw a 10-point systolic and 5-point diastolic drop in their mean blood pressures. And so even though this was only a 6-month program, if these improvements were maintained, I think we can reasonably say that these patients would have a lower risk of some of the well-known complications of hypertension, things like stroke, chronic kidney disease, cardiovascular disease, atrial fibrillation, vascular dementia, and likely others too. And so I think this MAP program was a really good example of the understand, navigate, activate approach for rising risk patients, targeting meaningful and measurable outcomes. So I appreciate your attention, and Cindy's going to share a little bit about some work they've done at her organization. Cindy?
Hello, everyone. This is Cindy Gaines. I'm with Borgia. And the journey I wanted to share with you starts back in February of 2015. As part of the Borgia's Medical Group, we are part of the Ascension Medical Group across the United States. And back in 2015, which is when we were just merging as a medical group, our national leadership team really literally said, we're going to put on a quality challenge for you. They announced this in February, and they said, you know, we want you to improve one metric, and they gave us a list of metrics we could choose from. And they were everything from diabetes to, you know, preventative care. But they said, you can take one metric and you have to improve it by 20% in 1 quarter. So between April and June, you need to improve that one metric 20%. And really the challenge was that we could improve faster than we were, and we weren't really challenging ourselves. And if you ever have the chance to meet me in the future, please say hello, but know that if you're going to challenge me, I will throw down with you. I am like, let's go. I'll take the challenge on. So I went to my quality team and I asked my manager, I said, so here's our challenge. What do you want to do? And her response was not what I expected, which was, we're going to improve hemoglobin A1Cs greater than 9. Now, I'm a nurse by background, and my first thought is you are not right, because you only check hemoglobin A1Cs greater than 9 once a quarter, and the probability of getting 20% improvement of a population to less than 9 that quickly, there were so many variables in it. And how are we going to get the patients to do this? And how are we going to get the patients to do that? And we have to do this in 90 days. So, but, you know, I trust my manager, and part of trusting was her really re-educating me at the time on population health and remembering what this was all about. So what I'm going to tell you is that population health is a paradigm shift. And what you heard when I responded to my manager was my professional biases. It's my history and experiences. We bring them to the table with us all the time. And they're not bad. They're just, I've been a nurse for 30 plus years. I have experience. I bring it to the table. And oftentimes it drives our decision making at the time. And the population and the perspective I wasn't considering is that back in the mid-90s, when we really got on the disease management, we need to do disease management, and we talked about we need a registry to manage our patients. It was about managing the patient in front of you. And frankly, we all got very good at that. We got very good at, when you came to my office, I gave you great care. When you came to my office, I took care of your diabetes. When you came to my office and you had the flu, I took care of you. I did preventative care with you because you were in my office. And the shift in population health, as we've moved into this era that we're in now, of managing across the continuum, managing over the longitude, is that we're responsible for that patient who comes to us, whether they come into the office and stand in front of us or not. And that's a different way of looking at it. And it's been uncomfortable for our providers. They've gotten much more comfortable with it, but it's uncomfortable. Well, the patient hasn't come in, that's not my fault. Well, but we're still accountable for them. And when you look at it from that perspective, what changes is that hemoglobin A1C is greater than 9 when you look at the population and clearly look at the definition. There's two groups of patients in there. One group of patients are patients who've had their hemoglobin A1C checked, and it's greater than 9. They are uncontrolled. The other group in this population are patients who haven't had their hemoglobin A1C checked in more than a year. And when you don't, in population health, when you don't know, they're considered uncontrolled. And that's kind of a mind-blowing concept, is you're accountable whether they're there or not. They don't get their mammogram screen. Yes, they're accountable. You're accountable for that because they're attributed to you. And when I thought of it that way, okay, you're challenging my my professional biases, because and this goes back to what Paul said. If you think of step one, which is understand, what I'm going to tell you is you need to spend some time understanding your data. You spend some time looking at your data, and if you do, your data will tell you a story. As healthcare professionals in our experiences, we want to jump right to solutions. And when we jump to solutions with hemoglobin A1C greater than 9, we jump to, well, how do we do better diet education? How do we do a better job of, managing their insulin? But is that the problem? We jump very quickly, and those are our professional biases and our history. So my manager said, let's look at the data, Cindy. Let me show you something very interesting. And what she showed me was that we had 2,600 patients who were greater than 9. But when you really broke the data down, 1,769 of them had not had their hemoglobin A1C checked in greater than a year. You know what? That's something I can move in a quarter. That's not about changing someone's diet. I need to just get them checked. So you really do start that step one of understand who your patients are is so important. Understand what the issue is. Let your data talk to you. Will lead you to a different place. What we also discovered in this process, that we were really good when you were engaged and activated and participating in your care. When you came to our office and got your care, those patients who were truly greater than 9, if we just measured them, our hemoglobin A1C greater than 9 was 9.4%. Well, 15% uncontrolled is the HEDIS best practice. 10% uncontrolled is the Accountable Care Organization best practice, and we're at 9.4. But it wasn't disease management anymore, it was population management. So it was really important to understand who your patients were, because then that step 2, that navigating, this will lead you to what's the right thing to do for your patients. We have limited resources and they are precious. And we need to make sure that what we're doing is the right actions based on the right problem so that we can make a difference. So we spent a lot of time looking at, not a lot of time actually, because we had to have this done by June and it was February. So we said we had the month of March to get this together. And it was about looking at who's the people, what's the tools, what do we need to have in place? And, I talked about the traditional registry. We're very blessed that we do have the WellCentive Population Health Platform. And that's really what we're talking about now, is really managing the health of the population of our patients. And we looked at what our outreach tools were. We spend a lot of time, look at the tools in your toolbox, because here's what I'm going to go to is, we talked at the beginning about risk stratification and the importance of that. You don't have to have an actual risk score to risk stratify. Dividing into was greater than 9 and who didn't need to be who hadn't been checked yet is a form of risk stratification. You don't have to have, it's great to have this tool, but if you don't, you still have the ability to stratify your patients. So don't be intimidated by, you know, I'm still with pen and paper. You can still stratify into those who have different actions that they need. And we call that A3 thinking, is to really spend some time on the problem, defining what the problem is, having that problem definition be driven by your data so that you go to the right actions. We looked at what we had. We had care managers who were embedded in our practices. We had a few every practice had a different amount of what they had resources to. And we had some quality coordinators that could work with these teams as well. The most important, I think, was that ability to really be able to identify these patients, which we did through our population platform. So the next step was really outreach. And as Paul said, this is the activation. We're talking about patients that we hadn't had contact with for more than a year, and we needed to activate them and engage them back into their care. And what was really fun in this process is that there was no right process. Meaning, when we work with practices, we have 18 primary care practices, and each practice measures at the practice level, and we measure at the practice, we measure at the provider level. And each practice had their own thought of what was going to work best. And we see that no matter what team you go into. You'll have someone who says, this is the way to go, and it will be completely effective. I know my patients. And someone else says, no, we need to do this. And what we decided to do in this process, and it was pretty engaging with our teams, is we said yes to it all. And with one caveat, you could only pick one outreach method in each practice. So if the practice at Columbia Avenue wanted to do personal phone calls by their front desk or by their MA, you can do that. But that's the only method you get to use in this pilot period, this challenge period. Someone else says, I want to use the portal because, you know, we need to be engaging our patients electronically. Okay, you can use the portal, but that's the only one you'll use during this 90-day period. And we did that to say yes because, you know what, we don't know which is going to work. And what's really important is that when you start a process is you commit to small acts of change. Really try them, see how effective they are, and then say, okay, now what would it take to hardwire this? What would it take to spread? So you can see that we had everything from, we had a couple of pharmacists out there where we had pharmacists engaging patients. We had electronic phone calls where we actually engaged them with electronic voice message to the patients. We had care coordinator outreach. We had proposed orders and letters. And what we found was all of them were pretty effective at the end of 90 days. The most effective, obviously, when you look at this, is the outreach by the nurse or by the pharmacist. And it was great to try that. It was great to see that was really effective. When we looked at that across our practices and saying, well, let me back up. They were all really effective. And I'll talk about the hardwiring this. But if we go to the next slide, you'll see the outcome. We started this challenge period with 29% of our patients were uncontrolled. 29% of our patients were greater than 9. And that's on the next slide, if you can move us forward. And by the end of June, our goal, if we looked at a 20% improvement, and I just want to explain this because I always get questions. They'll say, well, Cindy, a 20% improvement, 20% of 29%. So our goal was to get to 23.7 by the end of June. And I will tell you, most of our healthcare ministries did not choose to do this one because they said it couldn't be done. And what you'll see is that we got to 19% by the end of June. So we exceeded our 20% improvement, and we really did celebrate that. We blew it out of the water. And and that was impressive to all, it became one of, you know what, the rest of Michigan, what we call Ascension, Michigan, which includes Detroit, Saginaw, Flint, and our Taos area. This was adopted as a goal for the next year that said if Borges can do this, we can do this as a state, and our goal needs to be our goal for that following year, fiscal year, became that we would take that from 19% and get to 15%, which is our HEDIS best practice. I talked about the interventions and the ability to say yes to the intervention, but limit to what, only one to a site. The sites knew that we would come back and we would hardwire one intervention into place. And when we looked at our effectiveness of our outreach, we said, you know, that having the care coordinator was amazing, but it was a pretty expensive way to do it, and we weren't sure it was it was very effective, but it took them from other things that we needed them to do, which was actually managing transitions of care and working with diabetic patients who were out of control. It wasn't using them to the best of their license to have them making phone calls, asking patients to get their hemoglobin A1Cs checked. And the same with the pharmacist. So what we did decide to do was let's try one consistent method across our entire organization for the next year and see if we can move from 19 down to 15. Because what we saw was we did a great job of understanding, and we knew we were great at navigating you if you were in the system. And that's where we wanted those pharmacists and those nurses and the providers to focus. What we had to learn was how to activate our patients differently. And we did pilot what was called a panel coordinator, and it became a standing FTE for us. But I did propose having an MA level type of entry level person whose whole job was to engage patients on the phone. So let's take that list of, and they do more than diabetes, but take that list of diabetics that we don't know what their hemoglobin A1C is. They review the record to say, do we have it in the record? If they don't, they are then electronically proposing an order to a physician or to a mid-level or advanced practice provider, and getting an order from them. And then they're calling the patient and letting them know, we would really like you to get your hemoglobin A1C checked. And it includes anything else they may be missing, and they mail it to their home. And we did find that was 12.2% of that was effective, and we felt like an MA level position that was using them to the top of their job category and not using others at a lower level. And so if we, after a year, we did at the end of fiscal year 16, we did achieve 15%. That was our outcome. That was our goal, to get to 15%. It has maintained as a goal. We've had it, it's our third year in a row now, to have a goal of being at 15%, maintaining or being at 15%. And we've been able to do that. The rest of Michigan hasn't caught up to us yet, but we are leading the state. We are leading our Ascension Medical Group with 15%. It's been at 15% or lower for the past 3 years. And that has because, and what I would say is, we took the opportunity to hardwire, and I won't don't undervalue the need for that. We're very good sometimes at focusing work, and it'd been very easy to go. We went from 29 to 19%. Okay, what do we want to do next? And I actually appreciated that we were challenged to get to 15, and that we've had this goal for a couple of years. Not that we didn't have other goals added to it, but we took the time to hardwire it. And hardwiring was saying, can we do this? That panel coordinator worked really, really well. And that became an ongoing resource that we had, along with our technology, our Wellcentive technology, to be able to really look to manage these patient population and activate them. It's been hardwiring in the process of proposed orders and connecting to the patient's homes. And it was interesting because we've seen the impact of this work, and you all know it working with your health plans. Your diabetic scores score very high in your incentive metrics or your risk sharing contracts. They score very high, diabetics, as well as some of the preventative screening. And what we saw in this same time period is that 6 of our primary care practices became recognized in the top 20% of quality in the state through Blue Cross Blue Shield's physician group incentive program. We had in the past had 1, and we went from 1 to 6. The other thing is we have this as a goal in this current fiscal year, again, because the state is still working to get to 15%. We've always seen a bump up in the winter. It went from 15%, we'd bump up into the 18.5% over the winter. And the philosophy was that our snowbirds had gone to south for the winter, and we'd catch them in the spring. And it always came back to 15. It's been very exciting in this fiscal year is that we've not had a bump up this winter. It's actually continued to fall. And we're now in the 14 point something percent of uncontrolled. And when I go to the quality team and I go to the physicians, they don't even see this as a project anymore. They don't see this as a goal. They're like, well, this is just how we do it. And that told me we were hardwired. And a big part of that, and I will stress this because I know I have just a couple minutes and then we'll turn it over for questions, is a really big part of hardwiring of this was aligning these outcomes with our providers. We have 10% of our providers' annual income is tied to performance. It's an 10% on top of their pay that they can have in quality incentives. And the first year, the provider said, instead of measuring us as a medical group, would you measure us by practice? Because some of us do this way better than others, and we'd like to have credit for that, and we did. And then in the third year, this past year, they said, you know what? I want to be measured for my individual performance. Hold me accountable for me, because my partner may not be doing as well, and I want to make it so he has to stand on his own. So as we've hardwired the processes to support them, we also aligned their incentives to achieve them. And when I heard them all say, and this was just a few weeks ago, getting ready for this and thinking through this, they said, oh, it's not a project anymore. This is just how we do business. And so I encourage you to not be afraid of risk stratification, because you can do it with a RAF score. You can do it, but you can also do it by just really spending some time with your data and letting it tell you a story. Because if you understand your patients and navigate them and activate them, you can make a difference in their care. Thank you.
Thank you, Cindy, for such great examples. It's encouraging to see that the practices have see this as the new way of doing business, and some questions coming in for us to sort of take a look at. So one of them is around, you talked about using the data, and one of the challenges that we see when we work throughout the country is the trust of that data. So at the end there, you described how docs wanted to be measured individually. And one of the things we hear a lot about is, well, my patients might be different, or I'm not exactly sure I trust that data. So even if you don't have all of the capabilities you need, how did that work in your organization with building trust with data at the center of the analysis?
Absolutely. I'm going to tell you a story because it's my data story with Dr. Duranzo, who is one of our primary care providers. And he told me prior to my role, I was Vice President of Quality. And he told me back when I was in quality that there were 3 stages of data trust for physicians. And he aligned them to the stages of death and dying with Kubler-Ross of, you have denial and you have anger. And he went through that and he goes, data management's much like that with providers. The first stage is, this data is not real. This is wrong. You can just leave the room. And I can tell you, I've been kicked out of many rooms. The second stage of data management is, there may be some merit to what you're showing me. Let's look at this some more. And the third stage of data management is, where's my report, because I can't manage without it. And I will tell you, we started at stage 1, and a lot of this is spending time with your providers, hearing what's wrong in the data, and working with them to fix it, and building their trust. And I can tell you, one of the big challenges was we have one integrated medical record, and as much complaining as providers do about medical records, and none of them are perfect. When they find out other people have many to work with, they're pretty happy. But in our medical record, what we found is that patients were given diagnosis of diabetes that we wouldn't consider diabetes, meaning that if you, there's medications that are for weight loss that are also used for diabetes management, and some health plans will label you a diabetic because you were put on that, even though that's not the reason. You went to a specialist, and the specialist said, oh, I think you're diabetic. A lot of this was, as we integrated the record, spending time hearing what they did and spending time with them cleaning up our medical record. This was not a journey we did overnight. This started 8 years ago, and we started cleaning it up and listening to them and gaining their trust. And, you know, your goal is to kind of live between stage 2 and stage 3 of this. Hear what they say. There's usually merit in it, and sometimes it's just false information they have, but they need to be heard, and making it real to them. And because at that point, then they want to see their data. I would like to see, when my patient comes in, what their gaps in care are today. And we still fight it. You know, that patient who, well, they showed up as needing a mammogram, and they don't. They've had their breast removed because of cancer, and you know what? That's an issue with, we never put that diagnosis in. So let's correct this. So it became really a teaching opportunity to what needs to be documented in the medical records so that that patient shows up appropriately. So I would say invest in spending time with your providers.
That's really helpful. I'd like to open it up to anyone online who would like to ask a question. We have a few more questions that have come in through chat, but anyone else that would like to ask Cindy or Paul, please go ahead. Okay. Paul, in your role as, you know, recently you practiced for the last 20 years, there's a question around your leadership role as, you know, the financial and the executive roles that you've played. So not only as a provider, but how did you help bring the providers along in that process? And do you start seeing financial results here?
Well, so in our area in West Michigan and Michigan in general, there, you know, for some time now have been quite a few different quality programs. Commercial payers, especially Blue Cross and Priority Health in Michigan, have been fairly progressive with encouraging providers and provider organizations to work on population health in various ways. And so, you know, I think that that's been very helpful, because along with the federal programs and other quality improvement programs that have come on the scene over the past 10 or 12 years or so, there's been a reasonable amount of financial incentive for our providers to get engaged with population health management. And so I think it's been maybe easier in Michigan than in some places that we've seen. And I certainly do think that that makes an impact in the attention that the providers pay to it. You know, I think that in terms of getting the providers engaged with the process, I was smiling as I was listening to Cindy's description there about Kubler-Ross, because we went through all that as well. But you get the providers engaged, I think, in one way, by ensuring that you are listening to them. The data quality is really important. And if they believe that they can make an impact, they can understand what they're supposed to do, and that they can take action to do that, to improve the care in various ways, and actually focused ways for their patients, and then see the improvements, the outcomes, so they get that feedback that your effort has been helpful, not just by looking at graphs like Cindy showed, where you see improvements in your diabetic care, but also because you can see that there's been a financial incentive to do that. I think that combination has been, my network was very helpful for getting providers engaged and keeping them engaged.
Yep. There's another question, Cindy. You mentioned that you have one record. Someone's wondering how this works. In a lot of the places throughout the country, it's not on one record. Do you guys have any advice for the question around how do you deal with this when you're on multiple systems?
I think that's where I think having some type of platform that integrates the data, because what I would say is we have one record, but we have data sources that come in from other places, and we use our population health platform, our WellCentive platform, to integrate that data. So we actually have the providers focus on documenting in the record, or the staff, and then we have that record interfaced into the platform where we can pull the measurements and we can see what the gaps are. We can see who's had services, who's not had it, what their needs are. And we have we have outside labs that are interfaced into that, so that we can pull that information into one platform and look at the patient as a whole. And it can work much the same way if you have more than one medical record, is to have them interfaced into one platform that integrates that clinical data together for a population health management tool. And I would say that's where it does become very challenging if you don't have an integration platform to do that. And there's more than one integration platform out there, but where I've seen it successful is where you can pull, you don't focus on going into each record, but having basically interfaces or abstractions into one platform where you can integrate that data.
That makes sense. So another question for Cindy, you said that this was hardwired. Are there other areas that you use this strategy for? You talked about the different techniques. Someone was interested in how, what are the other things you're focusing on next? Currently we have a 2-year goal around colorectal cancer screening. So we were given, if we looked at the end of, so a year and a half ago, we were at 59% of our patients had colorectal cancer screening, and we used much the same type of process. We had a 2-year goal, so our goal is by the end of this June that we will have had a 13% improvement, and that we would gotten our metric up to 66%. I can tell you we're currently at 75% of our patients have a colorectal cancer screening. So I have a bit of a throwdown right now with Wisconsin that we'll get to 80 before them. But it's been much of the same structure of getting focused. How do we want to activate the patients? And also, I go back to that navigating that patient became really important in the colorectal cancer screening, because there's different methods that meet the requirement. Of course, colonoscopy is the gold standard, but a lot of patients are afraid of them. They have a lot of fears around them. They're invasive, they're expensive in a time when my out-of-pocket copay may be $10,000. So really, how do we do a fit test? And it's okay, and let's get that done. But it's been a lot of using these same techniques. We did that with mammogram screening as well, and have moved these metrics significantly. Again, spending time first, let your data talk to you, understand what's the issue. With mammogram, it was interesting. Everybody thinks it's the problem is the older population. It's not. We broke our data down by age group. Internal medicine was much better at it than family practice, and they had the older population. The population who really questioned it and were hard to engage was our 40 to 50-year-olds. And it was a population who's well-educated, well-informed. They knew that there's questions about, do you need it, do you not need it? And we had to think about how to engage them differently and how to activate them differently in their care. So yeah, we've had a couple of great, this is
our third project with that, using these techniques.
It's really great. Well, we're going to wind down now. We've had some really great examples of both process and innovation along how we deliver care, and how that insight spans not only, I think, Cindy, what you said, this is not just a project, but this is how we do business. So really appreciate all of the insights and figuring out how to catch these folks earlier. Thank you, everybody, for joining, and we appreciate your time. Have a great day.